Sri Lanka is an island located in the Indian Ocean in South Asia. According to the media population estimated by District and Sex 2013 to 2018 report, it has a population of about 21.7 million, almost half of them are females. Yet, Sri Lanka dropped 14 places in the World Economic Forum's Global Gender Gap Report in 2021. Report places where Sri Lanka is at 116 out of 156 countries. Generally, women in Sri Lanka are more vulnerable than men because they earn less and work longer hours, particularly in the estate sector. Women have unequal access to resources, extension services, and markets, and are consigned to the roles of unpaid family workers and home gardeners or agricultural laborers with lower wages than their male counterparts. 50% of Sri Lankan youth have limited knowledge about sexual and reproductive health. There's no comprehensive sexuality education included in school curriculums in Sri Lanka, and contraceptive methods is an area that is not included at all in the education. Teenage pregnancies in Sri Lanka is at 5.2%. In Sri Lanka, about 360,000 women become pregnant every year. 1 out of 3 are estimated to be unplanned pregnancies. As of Family Health Bureau data from 2017, Sri Lanka is with a maternal mortality ratio of 39 maternal deaths per 100,000 live births, recorded one of the lowest maternal mortality ratio in the South Asian countries. The cause-specific maternal mortality ratio due to abortions has declined in the recent past, yet it remains as one of the top 10 reasons for maternal mortality. 12% of maternal deaths in Sri Lanka are due to septic abortions, where it is the second most common reason for direct maternal deaths. Abortion in Sri Lanka remained restrictive under the Penal Code of 1883, where Section 303 of the Penal Code emphasizes that anyone voluntarily causing a woman with a child to miscarry is subject up to 3 years imprisonment and or payment of fine, making causing an abortion is a criminal act. In Sri Lanka, abortion is legal only when mothers is at risk, where the miscarriage can be caused in good faith in order to save the life of the mother. The penalty is imprisonment for up to 7 years and payment of a fine if the woman is quick with child. The term quick with child is a term which is used while not defined in the code. Refers to an advanced stage of pregnancy. A woman who induce or perform her own miscarriage is subject to the same penalties. If the miscarriage is caused without the consent of the woman, whether she is in an advanced stage of the pregnancy or not, the person causing it is subject up to 20 years imprisonment and payment of a fine under Section 304. The same penalty is imposed if the woman's death results from any activities carried out with the intent to bring about a miscarriage, whether or not the offender knew that the act was likely to cause death. Section 305. Given the country context where access to safe abortion is restricted, there is lack of credible data around abortion rates and realities in Sri Lanka. Therefore, incidence of abortion is believed to be considerably higher than is commonly acknowledged. According to the 2016 DHS data, the total demand for family planning among the currently married women 15 to 49 years of age is about 72%. An alarming factor is the prevalence of induced abortion among married couples being 94%, with an abortion rate of 58 per 1,000 among ever married women. Sri Lanka records a 64.6 contraceptive prevalence rate, yet a national survey conducted in 1999 reported an abortion rate of 45 per 1,000 women aged 15 to 49 years. However, it is estimated that around 600 to 700 abortions are carried out daily in the country. The same study showed that the problem of induced abortion was mainly among the urban and semi-urban married women in the 25 to 39 age group with two or more children. This shows that even with legal restrictions, people are accessing unsafe abortions, where some unqualified individuals perform surgical or other methods of abortions in hygienic settings, or people access medical abortion using the pill. But in Sri Lanka, most abortion care is freely available in public and private hospitals as part of primary health care, as of the Sri Lankan Ministry of Health issued the National Guidelines on Post-Abortion Care in 2015. This means no legal action can be taken at this stage, and medical care providers do not need to report these cases to authorities. The guidelines stipulate that any woman who undergoes an illegal abortion can seek medical care for complications, if needed, at any government facility without fearing prosecutions, where the health service providers have to provide post-abortion care services without their moral and or religious beliefs. The guidelines, however, recognize the need to have emergency post-abortion care services even at the most basic rural aid posts. Further, the guidelines recognize various methods for management of incomplete abortions, including manual vacuum aspirations, dilatation and evacuation, or drugs such as misoprostol. The Ministry of Health of Sri Lanka has issued detailed guidelines on the use of misoprostol, which includes its role in management of miscarriage in the first and second trimesters, or that for incomplete miscarriage in the first trimester. However, misoprostol is not included in the essential medicines list of Sri Lanka. Because of this post-abortion care, health risks for women in Sri Lanka after unsafe abortions have been reduced, and the number of deaths has been reduced as well, but unfortunately lack of women and girls aware on these and therefore hesitate to access post-abortion care due a complication. In Sri Lanka, abortion is only permitted in cases where pregnancy or childbirth is life-threatening to the mother. In addition to the political environmental constraints, abortion faces immense barriers triggered by socio-religious perceptions. New religious group formations, which happened in Sri Lanka, recently slowed down the advocacy efforts on safe abortion and also contraceptive mobile clinics to a greater extent. Discussions with religious leaders had already been built up, and then everything had to be stopped. In Sri Lanka, religious leaders have a big say in legalizing safe abortion, therefore sensitizing them and getting them into an agreement is very much necessary. Right now, Sri Lanka is going through one of its worst economic crises since its independence in 1948, marking by soaring inflation, food, medicine, and fuel shortages, rising commodity prices, and low supplies of foreign reserves. In April, Sri Lanka defaulted on its foreign debt. This economic stress prompted mass protests and a political crisis that came to a head in July, with then President briefly fleeing the country. This crisis has had a serious impact on the enjoyment of human rights for the entire population. With the country's foreign reserves depleted, the nationalized healthcare system cannot afford to import medicine and medical supplies in sufficient quantities. Sri Lanka relies on imports for about 85% of its pharmaceutical needs and about 80% of its medical supplies. The country imported food insecurity and declining incomes can exacerbate and or lead to increased rates of domestic violence within homes, in addition to the other forms of gender-based violence. putting women and girls at risk. Lack of access to food, medicine, and fuel, as well as curfews confining women to their homes, can exacerbate violence in relationships as well as prevent women and girls from seeking help and needed healthcare services. Shortages of life saving medicines will also lead to an increase in preventable health complications before, during, and after delivery, and where women and girls may face challenges to find pills to perform medical abortions or else have to pay an amount that they cannot afford to get pills, even putting them to a risk of sexual bribery and victims of sexual and gender based violence. The crisis threatening access to life-saving sexual and reproductive health information and services for women and girls, where it will result to an unintended pregnancies, putting women's and girls' lives at risk, where they will adapt and revert back of unhygienic and unsafe practices to access abortion, or has to continue with an unintended pregnancy which will impact them heal and well-being and especially affecting their overall well-being. For decades, there have been calls for reform, including proposals by the Law Commission of Sri Lanka in 2013 to legalize abortion, at least in cases of rape. However, successive governments have failed to bring new legislation. Isn't this the high time for Sri Lanka to reform 150 years old law? The government needs to act taking in mind that it is a basic healthcare need for millions of women, girls, and others who can become pregnant. Further, with relevant authorities, they need to address the misinformation and stigma around abortion. Ending a pregnancy is a common decision that millions of people make. Every year, a quarter of pregnancies end in abortion. When undertaken by a trained healthcare provider in sanitary conditions, abortions are one of the safest medical procedures available. Safer even than childbirth, and women and girls can access medical abortions safely without accurate and comprehensive information. Many countries are starting to change their laws to allow for greater access to abortion. Over the last 25 years, more than 50 countries have changed their laws to allow greater access to abortion. At times, recognizing the vital role that access to safe abortion plays in protecting women's life and health, we need to realize that people have abortions all the time, regardless of what the law says. Criminalizing abortion does not stop abortions, it just makes abortion less safe. Criminalizing or restricting abortions prevents doctors from providing basic care. Criminalizing abortion is a form of discrimination which further fuels stigma. Almost every death and injury from unsafe abortion is preventable. Access to safe abortion is a matter of human right.